we have Julie Letts, who's the Manager Clinical Ethics and Policy Unit with the Ministry of Health. We have Rob Wilkins, the Palliative Care Network Manager with the Agency for Clinical Innovation, and Bernadette King, the Program Lead for End-of-Life Care Amber Care Bundle Pilot. So welcome to you three. I understand you're doing a trio presentation, so welcome, and I'll hand over to you.
Good morning. On behalf of Rob and Bernie, I'd like to thank the local health district, in particular Ken Hampson, for the invitation. Can I just ask for a show of hands? How many of you are health consumers? And how many health managers? Clinicians? You can put two hands up. Other? All right. Rob and Bernie or another colleague from CEC are actually going around to local health districts at the moment, talking about the work that's underway around the end-of-life reforms in New South Wales, and it's they're largely with clinician groups, and so it's a real pleasure to be able to speak with a health consumer predominant group today. This is an extremely important area that really for a long time has not received the kind of attention that probably it's needed given the complexities of the problem. There seems in the last couple of years though to be a confluence of things that have come together to have made really, I think now, the time in New South Wales for the kinds of reforms we need to happen. There's been significant amount of work from the three of our agencies over the last few years in consulting on the nature of the problems, why it is that end-of-life care is so challenging and so difficult to get right, and what are the problems with trying to plan in advance for them. In addition to that, our Health Minister, Minister Skinner, has made this area a government priority, and I think when those things come together, you start to see change. I think probably all of us, whether we've been clinicians or whether we've had family members, have seen instances where end-of-life care is not what it should have been, and I think probably these things, either singly or together, really kind of describe what the nature of those problems when they go wrong. Either not knowing or not being able to honour someone's wishes. So in other words, a conversation hasn't been had earlier in life about what someone would want at end of life. When those decisions are made precipitously, when someone deteriorates clinically at the end of life, when there is an escalation, as there often is, in unwanted or unwarranted treatments, often all the way to intensive care, often with needless suffering if that's something that person wouldn't have wanted. There's not infrequently conflicts with families, within families and between families and treating teams, and there's a distress associated with that for everyone involved, and there's often a kind of residual guilt that can go around making decisions where those haven't been previously informed by what that person would want. And finally, for health professionals themselves, there's a stress, and I think often a moral distress, in circumstances where there's a sense that what's being delivered is not right in that circumstance. The US and the UK have been at this for nearly 40 years trying to improve this area, and it is an area that seems to be resistant to ready solutions. And so why is it that end-of-life care has been so difficult to improve? And I think, first of all, it's complex. It involves not just the person themselves. It's not simply a matter of stating your wishes and that's that. Decisions are made within family contexts, and none of us are an island, and how are those decisions then relayed into the health system? It's unstable. People do change their minds through illness. It's, you don't know what the journey's like till you're on it. And those of you who've had children and made birth plans, often the decision you make when you're well or you're not in pain can be different to the decision that you make as you move through that illness or condition. And that makes, therefore, decision making at various time points difficult. It's uncertain. Prognostication is a difficult science in medicine and healthcare, and uncertainty really is ubiquitous, and that can be very difficult for both patients themselves and families, and indeed clinicians, to really advise patients and make decisions soundly in a prospective way. And finally, I'd say it's unpopular. It's a spiritually challenging area, but more than that, there's, as you'd all recognise, a death talk taboo. And in a culture where we talk about living with chronic illness and fighting against cancer, that leaves very little space for conversations about what you would want as end-of-life approaches. So, these are just some of the challenges. There has been a lot of activity, as you will probably be aware, in New South Wales. Our agencies and others have been undertaking often very iterative consultative processes. With a number of strategic pieces of work have been completed, and it's pleasing and not by chance that we have actually found in going through those consultative processes similar themes. Similar kinds of solutions seem to be emerging, and so these important pieces of work, the Advanced Planning for Quality Care of End of Life, state plan around how to embed advanced care planning, was released last year. I'll let Rob and Bernie talk about their respective pieces of work, but as you can see, there's a significant amount of work, and now it's time to sort of move forward and try and operationalise these things. So I might hand over to Rob to really give you a little bit more of a feel around the kinds of themes that have been identified through consultative processes. Rob.
Thanks, Julie. As Julie said, a lot of work in this sort of sensitive area has been going on over the last year or so. My agency that I'm from is called the New South Wales Agency for Clinical Innovation. Has anyone heard of the ACI, or the Agency for Clinical Innovation? Well, that's good. There's some nodding heads, which is new. It's usually most people have never heard of such a thing, and I hadn't heard of it when before I started working there a couple of years ago. So the ACI is one of those pillar organizations that sits alongside the ministry. We all have sort of unique roles. The Clinical Excellence Commission that Bernie works at, she'll talk a little bit about safety and quality. The ACI, we're the ones that have those clinical networks. So there's 34 clinical networks in the ACI, and the main body of work that the clinical networks do is to develop something called a model of care. So a year and a half ago, we started a palliative care network, and anyone can join it. Consumers, palliative care specialists, GPs, people that work in residential aged care facilities, anyone can join it. You just sign on and we send you email updates and whatnot. And importantly, the thing that we're working on right now, we've got 420 people across the state actually on the network, which is fantastic. But all with very differing opinions on all sorts of things. And as Julie said, the end-of-life issue is a very complex issue, and people have very passionate views. So we have a lot of lively debates as to what should fit in something called a model of care. So the model of care for palliative and end-of-life care service provision is sort of like an umbrella document that's supposed to be useful for local health districts, for service managers, for people in the community. It's an enormous undertaking. So there was a group of about 15 to 20 people, and they spent about 2 or 3 months coming up with this vision for the model. The model is to ensure that all New South residents have equitable access to quality care based on assessed need as they approach and reach the end of life. And the unique bit about this vision was that it was very patient-centered. We were very clear that we didn't want a vision statement that said that health services get it together, or that there's increased resourcing for GPs, or increased resourcing for specialist palliative care providers. We wanted to make sure that the goal, the vision for our model of care, was that all New South residents, based on their need, have access to some sort of care. And as Julie said, the type of care changes depending on what your needs are, where you live, and that. So we spent about 8 months traveling around the countryside. We went to every LHD, including this one, to interview people about what they thought were some of the gaps and challenges around providing care to people. We spoke to over 1,200 people. As Julie said, the problem is socially complex. People have differing perspectives. And it's also what they call a wicked problem, which means if you develop a handy solution here, it can impact and activities over there. So it's a very slippery area of work. It's also an area of work where health isn't just the key player. There are a number of other key players out there that are actively involved in providing end-of-life care. And as soon as you start getting that interjurisdiction, cross-sectoral sort of approach, it gets really messy, but it's a necessary messiness. What I'd like to do is give you some highlights as to what we found, and a lot of it won't be surprising to you, and a lot of it supports the work of the CEC and the ministry as well. And before I do that, I want to put forward this triangle. It's the population-based approach triangle, and it applies to a whole bunch of health issues. But when we're talking about needs-based care, I think it's really important to describe how various patients' needs sort of fit or match with service delivery. So at the very bottom, you've got these sort of very crude categories. One's called non-complex. And this is the biggest cohort of people in the population. And they're considered to have non-complex needs, whatever that is. And the upshot of that is that most primary care providers should be able to meet all the healthcare needs of that cohort of people. So your GP, your medical specialist, your geriatrician, your staff in your residential aged care facility, the staff in acute care hospitals should be able to provide a level of quality care to you as you're in your last year of life with no reliance on specialist palliative care providers. In theory, this is all in theory. And then you've got the intermediate group, intermediate complex issues, which means that from time to time you're going to have some pain management or symptom management issues that are complex. You're going to have some family issues, you're going to have some finance or legal issues that are complex, and you're going to have to dip into the specialist palliative care provider's expertise. And then the top pyramid, the complex one, this is people with the most complex needs. These are people whose needs are met by specialist palliative care providers primarily. The problem with operationalizing a triangle like this is who decides what level of complexity you have. We have no standard measurement for that. And when we spoke to a lot of people, we found that the more we got to know patients, the more complex their needs became because we started to better understand their realities, their relationships and whatnot. So deciding who's complex and non-complex is an absolute minefield. But I think what this triangle usefully does is it shows that palliative and end-of-life care should be everybody's business. Everyone has a role to play in providing care. It's not just quickly referring to the specialist palliative care provider. Your GP should theoretically have some level of skills to have those end-of-life discussions with you or your family, to talk about advanced care planning. People in acute care facilities and hospitals should be able to recognize that you're deteriorating, should be able to have the courage and confidence to have those difficult conversations with patients and family members. But we know that that's incredibly variable, and that was one of the key things that we found when we went around the state, was that there's an enormous amount of variability in terms of people's confidence, not just competence, but confidence to have these difficult discussions. One of the interesting things we did at the ACI, we've got this health economics and analysis team that works there, and they're the number crunchers. So they were able to do something eerie called the fact of death analysis for us. And what that was is they looked at a cohort of patients in their last year of life in New South Wales. So it was something like 37,000 people in their last year of life who were having an expected death. And they looked at how many times they went to the hospital and the conditions that they went to the hospital under. So we had 37,000 deaths. In 1 year, there were over 150,000 hospitalizations in New South Wales. The average length of stay was 10 days. The normal length of stay is 4 days for people, but people in their last year of life was 10 days. They had repeated unplanned admissions, which means that all of a sudden their symptoms or their pain went through the roof. They had to call the ambulance at 10 o'clock at night, 2 in the morning. They had to go to the emergency department, causing an enormous amount of stress for everyone involved, including the health workers, because often when people come through the emergency room, they don't know anything about them. So they don't know what their care goals were. They don't know where their advanced care plan is or if they have one. They don't know what the family's wishes are. They often don't know where their medical records are. Extremely expensive, approximately 984,000 bed days at an estimated cost of just $900 million. So it's a big health issue. The costs incurred by people in their last year of life for hospitals is enormous. So there's a financial impact, there's an impact on the health workers in emergency, in hospitals, in ambulance services, but an enormous impact on families and patients and carers. Okay, so they make an enormous intense use of admitted acute hospital services, lots of unplanned admissions, multiple admissions for a year at least, and a high number of deaths in hospital. And what we want to do is improve that. We want to better skill up people to provide care so these emergency situations don't happen as often. When we went around the traps, we spoke to a lot of people in rural areas. We spoke to every rural LHD. What we found was that there was an enormous sense of pride, creativity, ingenuity, lack of resources out there to provide care, and I'm sure this is no surprise to all of you out there. This is a really good quote. We provide a good, flexible service for our community, often reaching after hours, but as long as we do this, there will be a feeling that all is fine with the way we're resourced and supported. It's not okay. Some staff work 7 days a week or well into the evening. The next one is, we're very good at thinking outside the square. We cobble together a service that's appropriate for the patient. Try to help rather than explain to people why we can't help. And this was a very common theme, creative, adaptive approaches, very few resources. The risks around this approach is that it's based on informal approaches. It's based on people working beyond the scope of their practice, after hours, traveling enormously long distances. So that's a very vulnerable situation to put our healthcare workers in. And in the government plan to increase access to palliative care, they talk about formalizing up a networked approach, making sure that the goodwill out there among rural healthcare workers is accompanied with formal support mechanisms, that people aren't doing it off their own bat, that people are being paid, that people are working with the amount of clinical support that's necessary. Is that sort of familiar, that sort of theme? The issue around recognizing the deteriorating patient or the dying patient, this was from a rural nurse. Sometimes people aren't getting recognized soon enough for palliative care, particularly with chronic illnesses. There's huge gaps identifying who is in their last 12 months of their life. So what we want to do is be able to identify people who are what we call approaching or reaching the end of life. Because what we know is the sooner they're linked in to systems, the sooner we have those difficult conversations with family members and with the patient, the sooner we set some goals of care, possibly draft up an advanced care plan, the better everyone's able to prepare for the inevitable down the road. So there'll be less critical incidents, less unplanned admissions, less trauma for the family, and an enormous amount of cost savings as well that has to be said. Okay, this is a bit of a plug for Advanced Care Plans, which is the body of work that Julie's working on right now. A rural emergency department person said, "We see a lot of patients at the end of life. We make quite a lot of decisions around a patient's care. We sometimes are frustrated at the lack of decisions prior to them coming to our department." And a rural intensive care liaison nurse, I think that was up on the North Coast, said, "I try to work with families on wards. It takes a lot of time talking to families, defining the limitations of care." And again, it's about not having that surprise, knowing that when someone comes in, it's hopefully as planned as possible, that you know something about their conditions, medical conditions, you know something about the medications they're on, you know something about their wishes in respect to their care, their goals of care, hopefully even have an advanced care plan. Lastly, this was another ongoing huge issue that affects all of us, and it's about broadly the concept of communication. An intensive care nurse said a big issue with clinicians is not knowing how to communicate with families. One of the biggest issues for the clinicians is the family's expectations. They don't expect to have an end-of-life conversation. So it's not just the difficult conversation you have with the patient, who sometimes is much more open to having a not for resuscitation comment put on their advanced care plan. It's often the families that say, no, we want you to pull out all the stops. We want treatment no matter what. We want to extend life. And so that takes a lot of time and energy for the healthcare team to be able to negotiate and bring those two teams together to a common goal. And it takes a lot of time and energy. A key stakeholder says, as well as the cultural challenges in not discussing death and dying, this is an area that's complicated by ethics and law. It's also not well understood, and it's not well understood across the board. The advanced care plan stuff is quite complicated. It varies from state to state, and a lot of healthcare workers have a fear around litigation. Is it okay to respect the patient's wishes so that the quality of their life is respected and we don't try to extend their life? And that's a very dicey issue for a lot of people. People have very different views on this. The view you have for your patient may differ completely from the view you have to that of your partner, your loved one, your family member. So it's quite a big area and an enormous area of unmet need. We know a lot. We're not starting from scratch. We know what works. We know broadly what we need to do in terms of investing a lot of resource and energy into providing education and support to healthcare workers around better document development, around advanced care planning, a lot of skill development opportunities for health workers to detect the dying patient. And we also need to think really creatively about how we increase dialogue out in the community. That's another whole big basket of problems and that health doesn't have sole responsibility for. So if anyone has any great ideas about how we can raise awareness within the community, bring up this issue of death and dying and advanced care planning in a supportive, fun way, by all means, let us know. It's a tricky message to sell. 9 times out of 10 people would just rather not deal with it. So, all right, well, that's it from me. I'd like to turn over to Bernie, who's going to talk about a really exciting new pilot program that's happening around New South Wales.
So good morning everyone, I'm Bernadette King, I'm from the Clinical Excellence Commission, and as you've heard there's a lot of work being done by multiple agencies in New South Wales around end of life, and the Clinical Excellence Commission is one of those. The CEC is one of the pillars, one of the main bodies of health around looking at quality and safety in healthcare. Some of you might have met Karen Luxford last night. She's one of the directors of the Patient-Based Care Directorate, and you'll hear about Top 5 and REACH today. So they're a couple of the programs the CEC is also doing. Also, what you've heard today,
and especially through Rob giving you that great detail around the findings, is there's a real opportunity to improve the quality and safety of end-of-life care for everyone who accesses or comes into contact with our health services. And basically, that's all of us. So what the CEC is doing is one of the programs is trying to address some of those issues that Rob and Julie have brought up, and it's called the Amber Care Bundle. Now, health loves an acronym, and as you can see from Amber, we've got assessment, management, best practice engagement of patients and carers for patients whose recovery is uncertain. Now, it's very twee and it's very long, but I suppose the focus is around this program is engagement of patients and their families where recovery is uncertain. So taking some of those opportunities to have these early discussions. The Amber Care Bundle was developed by a palliative care physician and a geriatrician at St Guy's and St Thomas's in the UK. And that there's components or elements of that bundle, and it's about mainly prompting medical teams to start having those discussions when the patient is admitted and their recovery is uncertain. And it's as simple and very, very difficult, as Rob brought up about the communication, as saying to the patient, you are unwell. We will do everything we can to treat you, but we don't know. And that's a real challenge for medical staff to be able to say that we don't know. but we don't know whether you will get better. So let's put some plans in place. And it's not stopping treatment, you are still actively treating, but if something goes wrong, what do you want us to do? What is your wishes? What would your family like to see happen? And what would you, as the patient, want to happen? And as Rob said, a lot of the times we know that patients know they're not well. And a lot of times the families know they're not well. And sometimes we're finding that this is giving them the opportunity to acknowledge that we should have this conversation. That if you're that sick, that maybe this is the opportunity where we look at, do you want resuscitation? Do you want intensive care? And if that's appropriate, that's what happens. That is what the management plan is. So it's all discussed. And it's also giving the opportunity for those families to say goodbye. Where's the will? Have people come in and, see them, have that opportunity to have those conversations, have memories, make laughs, etc. And that's what they're finding with this program over in the UK. And then once that decision is made, it always can change, it's checked every day to make sure that this is still the way we're going to go. It's about making sure the team, the entire team, is aware of what the plan is. And that's just not medical staff and nursing staff, that's allied health staff, social workers, occupational therapists, physios, so that everyone is aware of what's going on for that patient. So that at 2 o'clock in the morning or on the weekend, when the normal team's not there that knows you, knows your family member, they will be able to come on and make sure that you are cared for and the family member is able to be cared for in the way that it was planned, in the way that you wanted, in the way that was agreed. It was interesting, we were flying down yesterday afternoon and a young girl asked the flight attendant, why do we have to have the windows up when we land? And she was talking to her and telling everything and she said, well, when we land, it's, some things can sometimes go wrong and we need to make sure that everyone can look out and if there's a problem, they can tell someone so that we're all aware of what's going on because it's safe. And I think that's one of the things around making sure these conversations are made, everyone's aware of the plan, and all staff are hopefully going to be treating your family member or yourself in the way that you want it to be. And the goal is to improve the quality of life, transparency of treatment goals and outcomes, and improve quality of death because it's safe. So where does it fit? So we say it's, of course, amber, it's in that area of uncertainty. So when you're usually well, no problems, and hopefully everyone will have their advanced care plan done so that it's already down and dusted. But in that area of uncertainty, this is where decisions are made so that if you do get better, if the patient recovers and they go back into the green, then you've already started those conversations and hopefully then it's improving and working on the advanced care planning. But if for whatever reason they don't recover and they then are actively dying, it's making sure that they are dying in the way that they want to die and their symptom control is really well managed. That's, as I say, we're looking at the patient, it's about the multidisciplinary team discussion, it's about the patients and families' engagement, it's about what the patients and the family want around the treatment when they are so sick that they may not recover. So expected benefits, and I suppose I'm talking about this program in that pointy end where Rob gave you all that information around the findings of their workshops, etc., around communication, the difficulty in recognising and identifying dying patients. And so by doing this program, which we're piloting at the moment, we hope we will have that better identification and recognition of patients who may die. Also better communication with the patient and the families, so that if there are issues within the family dynamics and we have discourse, there's time to sort that out before you become in the crisis situation where decisions have to be made. And hopefully it's better likelihood of the patient dying in the preferred place of death. And that preferred place of death may be in the residential aged care facility, it may be at home, but it may be in hospital. But also what we're finding, especially rural and regional hospitals, is that patients are transferred to the base hospital and they're actively treated there and they may die there. but it may be better for that patient to be transferred back to their local hospital where their family are, their friends are, so all the supports are. And that's a better death for that patient and that family. So that's about all. We are, as I say, we are just piloting that at the moment. It's in 8 hospitals across New South Wales. Western New South Wales is our rural centre where we're testing it, and we hope to roll it out soon. But it is the difficulties that we are finding to date. Is the main thing about is initiating conversations. It's about a lot of times also recognising when the patient is that sick is to have the conversation. And also, a lot of times doctors have built up a relationship with their chronic care patients and they don't want them to feel that they're giving up on them. So it's about what we have to do is that work that Rob was talking about together is around communication, education, around making sure the message gets out to everyone that this is not about giving up on them, this is about making sure the plans are in place so that the patient can die the way they hope to die. Thank you.
Rob mentioned that my major portfolio of work at the moment is around advanced care planning. I'll just give you a little bit of update about some selected activities that are current priorities. But we're wanting to really sort of open the discussion up, for a good 20-25 minutes of conversation. So this particular state plan was about 2 years in the coming. And it's an ambitious plan. There are some 49 action items in it, and while it's proposed to be rolled out over 5 years, to be honest, I think it's probably more like a 10-year sort of culture change. There are some significant changes that will be heralded through the work. But just to take a step back. To what is advanced care planning, and over the last decade I think there's been a kind of sophistication in people's thinking around what really makes for making this work, and there was for a long time I think an overemphasis on completing documents, completing an advanced care directive, and you do that and it's a one time and you talk to a family member and you put it in a drawer. And I think there's plenty of evidence now that that is not what advanced care planning is about if you actually expect it to impact on the care that you receive. And so importantly, it's about thinking, I know this sounds trite, but it's about thinking, discussing and documenting. And the discussions are iterative. And they're not just in the last year of life. In fact, if you want to get the care right at the end of life, you need to actually start, even when in healthy midlife, thinking about who would you want to make decisions for you if you couldn't. It's a much less confronting thing to think about, but a really important first step than trying to think about, would I want CPR or not, absent of context. And so those discussions can start, for example, with triggers. And Bernadette was talking about the triggers when someone comes into acute care. And the AMBER program really is about triggering people to think, might this person actually be approaching end of life? And so I think with advanced care planning generally, there are triggers that, life triggers, for example, when you have a divorce or you get married again, or there's a death in the family, you think about your will and your financial arrangements, and it's a good time to think about who I would want to make decisions, and is it time if I have an illness to think about an advanced care plan. And so really the focus that we've taken in this action plan is that we importantly want to embed advanced care planning throughout chronic life-limiting illnesses. So from the time of diagnosis to embed what is a normal clinical process to open conversations with patients about who they would want to make decisions for you. And then as someone moves through their illness, when you actually have more of an idea about what's coming down the line, depending on what your illness is, what things might await you and wouldn't you want them, and so on. So, and importantly, I think advanced care planning is about, I think it's not the same as just clinical care planning generally. It's about for a time when you can't make decisions, and it's about trying to keep your voice in the mix when you, for whatever reason, you may have had a cerebral bleed or you've dementia or whatever, and you're no longer able to make decisions. So, it's perfect. So really this diagram is really to emphasise that it's a phased approach. I've talked about this early phase planning when you're well. The serial conversations throughout chronic life-limiting illness, the way we're anticipating that being embedded into practice is that there are times, if you have, say, for example, chronic respiratory disease, there are what are called clinical signal events, so clinically significant events that indicate that your prognosis has changed. For example, the first time you get admitted to hospital. And so the chronic disease specialties will be thinking about how they can use those trigger events and really kind of routinise them, if you like, into clinical practice. And this sort of end stage planning is what seems to get the most attention, perhaps appropriately, but really to get this done well, you actually do need to start at least here. And so this end stage is really the kinds of, thinking ahead, and depending on how ill you are, would resuscitation be appropriate? That's a decision you need to make with your treating doctor. Transfer to hospital if you're in a residential aged care facility, and all, intubation and going to ICU and all of those treatment escalation matters. Really, these are sort of end stage decisions, not really to be made when you're in healthy midlife. I mean, what would you be deciding on the basis of? So, and the goal of all of it, obviously, is to try and match the care you receive as much as possible with what you would want in your former self. It is actually quite a conceptually difficult exercise, advanced care planning, sort of imagining your future states. However, and that said, it's not also a carte blanche. Therapeutic limits are real, and when none of us as patients can demand everything, there needs to be some potential benefit. So, picking up on some of the things that Rob was talking about, one of the things and certainly that I experienced through my own consultation work developing this plan, is that people recognise that this is complicated and people are desperate for it to be made easier. And part of making it easier, perhaps, is getting away from the plethora of documents that we've got in New South Wales at the moment. We've got like dozens of advanced care plans, all of them potentially useful, but it's confusing for people to know where to start. And so what the Ministry has started in the last year is we've developed a single resuscitation plan for the state, and these resuscitation plans are completed by doctors. They're formally called no CPR orders, but they're informed by an advanced care plan that you might write. And there's a new policy to support that. So this is a kind of moving to a standardisation that I think will help health professionals. And we've also just made the decision to try and look at all of the advanced care plans that are currently commonly in use and try and pick some of the best of them. It's actually very difficult to pick a one because it's not a one-size-fits-all. But if we can have a small suite of New South Wales Health recommended plans, I think that will go some way. The New South Wales government site, I think it's important to know that this is the premier New South Wales government site for advanced care planning. It's the Planning Ahead Tools website. And we are working, the Ministry is working with Justice and Attorney General who auspice this site to try and consolidate our materials and our tools and resources as much as possible. So there's information there for individuals and patients and families, and there's also information for lawyers, and there's information for health professionals. Rob said that there's a lot of misunderstanding around the law in relation to end-of-life decisions, and that's most certainly true. And most clinicians are certainly very anxious about litigation. There's actually a lot of myths about, for example, the status of advanced planning documents. I mean, everybody says, oh, we have common law, and so advanced care directives are worth the paper they're written on. That's not actually true. So that and a number of other myths, we pulled a group together with some of the best health law, legal academics in the country, the Guardianship Tribunal, Office of the Public Guardian, and obviously our own legal branch. And we've developed a case-based talking through some of the myths around the law in New South Wales, and that will be hosted on the Planning Ahead Tools website, hopefully by May. One of the sort of cornerstones of making advanced care planning work is that health professionals have a comfort and a skill and a permission even about opening what can be sensitive conversations to try and elicit preferences from patients without being too confronting is the hard bit of that, I think. And it's a skill, and it's not taught as well as, for example, diagnostic skills or surgical skills in medicine, and perhaps it should have more of a prominence. So we are just starting a project called the SHAPE Conversations Project, supporting health professionals in advanced planning and end-of-life conversations project, where we'll bring together educators and clinicians in a range of specialties to look at some of the best resources that already exist in Australia that support health professionals in practical ways to have these conversations. And we'll work with the Health Education and Training Institute to make those available. And finally, communication as a system about how all this is going is important. And the Ministry, we've started issuing newsletters quarterly about how implementation is going, and we're going around local health districts like this talking about where things are up to. So really, that's just a small sampling of some of the work that's happening. But it's exciting times, but it's incremental, and there is a frustration with that. Nothing like in this area will change quickly, I don't think. But we're heading in the right direction.